All right, welcome everyone. Welcome to the American Academy of Emergency Medicine's Justice, Equity, Diversity, and Inclusion section mentorship session tonight. This is the third installment of our mentorship series, and tonight's topic is racial bias in pain assessment. My name is Dr. Kristen Fontes. My pronouns are she, her, and I will be your moderator tonight. All right, so I'm just going to stop. Oh, you guys stop sharing. Okay. So tonight's program will be recorded and uploaded to the AAEM JEDI website within 48 hours. We really appreciate everyone being here, whether you're in attendance now or viewing this program later. But before we start, I just think it's really important to acknowledge that this session, like many of our sessions, is going to discuss the history and also current impacts of systemic racism. And that is inevitably going to be triggering. So if at any point you need to step away to take care of yourself, please do so. Your well-being is important to us. And so please don't hesitate at any time. This session is meant to be interactive, so we will have time throughout for questions, discussions, maybe just to kind of help me as I facilitate looking at the chat and everything. If you have a comment or question, maybe either just put it into the chat or raise your hand and we can find a space to call on you. You're also welcome to save any questions or comments for the end, whatever works for you. We absolutely welcome and encourage participation. We also hope to foster very open and respectful dialogue as well. And now it is my honor to introduce our speaker tonight, Dr. Kristen J. Smith. Dr. Smith is a clinical assistant professor of emergency medicine at the Hospital of the University of Pennsylvania. Her academic interests include health equity education for the emergency provider, medical student pipeline development, and mentorship. Kristen is actively involved in AAEM as well, which she was recently elected as the Secretary Finance Chair of our JEDI section. She also serves as the Leadership Work Group Committee co-lead for the Women in Emergency Medicine section as well. So she has a full plate, and I'm so glad that she is taking her time and lending us a bit of her expertise tonight. So Dr. Smith, thank you so much, and I will go ahead and turn it over to you.
Hi, so hello everyone. My name is Kristen Smith and I am, that was a great introduction. So yes, I am faculty at the Hospital of the University of Pennsylvania and I'm super excited to be the Secretary and Finance Chair for JEDI this year. I'm also involved with the Women in Emergency Medicine section for AAEM and serve as the chair of the leadership committee. So I'm super excited about that. So Dr. Fontes gave a really great disclaimer, but I just would like to kind of share some disclaimers that I have. I'm actually having an issue with my PowerPoint right now. I don't know if there may be a chance for you to share your screen. Sorry. But we can just go on to me kind of sharing some of my disclaimers. So I like to just give a groundwork before we talk about some of these topics. First off, the information here is all based on my own research and work. So this is outside of and separate from the work, any work that I do from my institution. So this is not on behalf of my institution in any means. Some of the topics in the presentation may be particularly triggering or sensitive. The intent is to learn how history informs current pain management and current treatment. You can feel free to excuse yourself from the presentation at any time if something gets too heavy or if there's anything that may be upsetting. Today, we will be focusing on pain assessment and management disparities associated with race and ethnicity bias. I want to make it clear that there are several studies that also support disparities in pain management based on other characteristics. The intent is not to exclude, but to educate. And then lastly, feel free to ask any questions as we go along. No question is silly or trivial. This is really meant to be educational and informative. All right.
Kristen, are you, sorry, I don't mean to like a break from the session, but do you mind, I don't have your slides. Do you think
Oh,
you
it didn't go through. Okay. I think it may be too large. Let me try one more time. It may allow me to go through. All right, thank you. All right, everyone. So again, we'll be discussing the impact of racial bias on pain assessment and management. And we discussed some of the disclaimers for thinking about this work as we move through. So here are the objectives. So we're going to discuss the historical context of racial bias, review literature relevant to pain management disparities, define implicit bias, and discuss mechanisms for pain management and managing your biases and anti-racism techniques. So I always like to start off these presentations with thinking about key historical events in US history. I think it's hard to think about issues related to healthcare disparities, health equity in this country without thinking of how this country was formed. This is just a very brief list of some of the historical events that I think are very relevant to this work. As you look to the left, you'll see the creation of the first medical school was in 1765. It was the College of Philadelphia. A little bit after that, there was obviously the Trail of Tears, where there was forced relocation of indigenous peoples throughout the US, and it led to over 60,000 really murders of indigenous peoples within this nation. Also, you'll notice that 1619 is when the institution of slavery really came about. It is not when the first enslaved person of African descent came to this country, but it's really when the institution came about and really the start of the transatlantic slave trade in 1619. And you'll see some other information there, but I think it's just important to really kind of have this timeline in the back of your head when you're thinking about these disparities. So going along with the historical perspective, for some of you who are history buffs, you may remember the concept of phrenology. So that is a pseudoscience that was originated in the early 1800s by physiologist Franz Joseph Gall in Germany. That his notion was that skull size pretty much differed by gender and also race ethnicity. And at that time, again, going back to the 1800s, it was really classifying persons as white, Black, and indigenous. And he made links between skull size to then indicate how large someone's brain was. And then he said that based on the size of the brain, your brain had different organs that were related to intelligence and kindness and civility. And he then said that these differences were the basis of how persons should be treated within society. So this historical ideology was really used to justify relocation of indigenous peoples and also slavery in this country. So here we will review how some of this information was then translated over to the US. So there are many other physicians that I could have listed on this slide, but there are 3 physicians that I think are pretty important to know when you think of the historical aspect of racism in medicine and how it's intermixed. So from the 1700s to the 1800s, really, it was when physicians in this nation were trying to make a name for themselves and doing research studies, and also the US was becoming more known in terms of the sciences and STEM fields. So phrenology at the time was being used to justify slavery, and this then trickled into the justification of using enslaved peoples for medical experimentation. So in the 1800s, there was a Dr. Thomas Hamilton, who was thought of at the time to be a well-respected physician in Georgia, who was also a slave owner. And he was known for doing many studies that were in an attempt to justify and find out about biological differences between Blacks and whites. So the information, the book on the left-hand side, if you look at the graphic, it's a book, it was an autobiography written by John Brown, who was enslaved by Dr. Thomas Hamilton and then went to freedom in Europe. And when he was in Europe, he wrote an autobiography and included a lot of information about the experiments that he was held victim to under Dr. Hamilton. Many of the experiments were very graphic. He talked about how he was burned, and the ultimate goal of those experiments were to determine that Black people had thicker skin than white people. And he also spoke about some other really horrific things that were done to him. There was another physician a little bit later on named Dr. Samuel Cartwright, who was a physician and professor of, quote, diseases of the Negro, who also did a lot of research at the time to discuss different biological differences between Blacks and whites. He was known for finding the disease of drapetomania, which, if you know anything about it, it was basically the notion that slaves who attempted to run away were somehow mentally insane. And the way to treat that disease was to whip and beat any slaves that you found who had ran away. And lastly, I see an error there, I apologize. It is Dr. J. Marion Sims, and I'm sure many of you have probably heard about him over the course of your medical education, but he is deemed the father of gynecology. He actually is a very controversial figure because during his time, he was known for really perfecting the technique of repairing vesiculovascular fistulas, and that's between the vaginal canal and the bladder during childbirth. And as some of you likely know, he did mainly most of his experiments were all performed on enslaved women without using any anesthesia. And if you look up at the right, that is a pictographic of one of the experiments that he was doing. He also went on to be the president of the American Medical Association. And he was the first physician in the US to have a statue created after his honor. And this was up until 2018 in Central Park. And it was only taken down within the last few years based on protest and social media outrage from people learning about the true history regarding this beloved figure in American medicine. So we're now going to move on to kind of what is pain and pain management after we've discussed some of the historical context for this talk. So pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in such damage. And usually pain is described as either acute or chronic. So chronic pain is when the pain has now lasted for more than 3 months. Here are some quick pain statistics. And again, most of the statistics that I will talk about in this presentation are really related to the emergency setting, because obviously this is AAEM and most of the people on this call are emergency physicians or physicians in training. So we know that approximately 140 million emergency department visits happen annually. And if you look here on the right, we have the AHRQ's top 20 diagnoses codes. And if you look at them, over 50% are related to pain. So this is just to highlight how important it is for you as an emergency medicine physician to feel comfortable with not only assessing your patient's pain, but also treating it. So this slide talks about the economic toll of pain. It's really more looking at chronic pain, but current figures show that 1 in 3 Americans suffer from chronic pain. Again, that is pain that lasts for over 3 months. The total cost of chronic pain is estimated as $50 to $60 billion a year. The value of lost productivity averages $335 billion annually. The annual cost of pain actually outpaces heart disease, cancer, and diabetes combined. Chronic pain is estimated to cost a total of $60 billion annually in lost productivity. So this is important when you think about patients coming in, they can't get to their outpatient pain management doctor, and how do you treat their pain and ensure that they are able to go back to work, which is their livelihood. The negative effects of untreated pain are vast, and there is new literature to suggest that it really affects your whole life. So as we know, untreated pain leads to a catecholamine surge, which causes tachycardia, increased risk for myocardial infarction from demand ischemia, leads to increases in ischemic stroke, increased bleeding events, increased risk for thromboembolism, because the patient or person who has experienced the pain usually is not moving around as much because it hurts to do so. Deconditioning, which then has an effect on livelihood and well-being, sleep disturbances, immune system impairment, susceptibility to disease, and increased risk of mortality. And I saw one study that listed the range of increased mortality for patients who experienced chronic pain being anywhere from increased to 35 to 85%, which is a huge range. It's important when you think about pain management that you consider multimodal approaches. These are just some of the therapies that you may want to consider in a multifaceted pain management treatment plan. So physical therapy, NSAIDs, opioids, injections, etc. So now we're going to move in how the intersection of racism and medicine play a part in disparities in pain perception. So there was a very interesting study performed by Hoffman et al. And published in 2016 that a lot of literature cites and makes reference to. It was a study that was done, it was a pretty complex study, but basically the study was to look at how medical students and residents, first off, viewed patients' pain perception, and then second, how they would then treat patients' level of pain based on how they viewed that patient's pain perception. So the first part of the study, there was a 15-item survey, which you see here, that was developed. And there was a study sample of medical students. It ranged from first year to third year medical students and residents. Unfortunately, a limitation was that they did not say how far along in their training the residents were, but also consisted of residents. And they delivered this survey and had the respondents rate whether they thought these different items were true or not. So 11 of these items are not true. And they then looked at, for respondents who listed or agreed with a lot of the untrue items, which were called false beliefs. So a lot of the respondents who said that they believed a lot of the false beliefs, they then looked at how would these respondents then rate a hypothetical patient's level of pain, and then how would they treat that same patient's level of pain? So they then made up two different cases that were identical, except they changed the patient's race, and then they gave the medical students and residents the sample cases and then asked them to rate what their patient's level of pain was on a 10-point Likert scale, with 0 being no pain at all, and 9 and 10 being the worst pain that is imaginable. And then the second part of that study is then they asked the students and the residents to then just jot down what pain management they would deliver. So here we see several items, and again, there are several items that are not true. So based on this table, you can see the false beliefs, and you can see the number of respondents who agreed with the false beliefs. So I thought very interesting was this actually doesn't correlate to the survey. So this item here that was asking people to say if they believed whether Black skin is thicker than whites. Amazingly, over 60% of all respondents in the categories responded that they believed that that falsity was true. And if you go back to what we talked about earlier with the experiments that Dr. Hamilton and Cartwright and Sims were doing, you think about how does this play into what is believed today by students in training and residents. So this was a bit concerning to me and also surprising. Overall, those researchers found that 50% of participants endorsed at least one false statement regarding biological differences between Black and white persons. And here we take a look at the information in regards to the average pain rating and the proportion of recommending accurate treatments. And basically, based on their analysis, they found that for respondents who endorsed a high level of false beliefs, they always rated their Black patients' pain levels as lower, and as lower by 2 points than respondents who did not have a high level of beliefs about falsities. They also the respondents who had a high level of false beliefs prescribed less opioid pain management. There was another study conducted by Staten et al. That shows that physicians underestimated pain scores for African-American patients by more than 2 points, 47% of the time, and 33.5% of the time for non-Black patients. Furthermore, pain scores were twice as likely to be overestimated for non-African-American patients. So putting this all together, basically these two studies just say that the physicians who were involved in the research study, on average, they had lower thoughts of pain scores for their Black patients. So they were rating their Black patients as having lower levels of pain, and they were less likely to prescribe opioid pain management to their patients. So now we're going to talk about some of the disparities in pain management. This slide just is a graphic to show all of the news articles that have come out within the last few years that kind of highlight this topic. There's more that I could have included, but I think these were some of the most salient studies. The disparities in pain management, you could create several slides on this, but I just highlighted some of the most important. There was a retrospective analysis of 5 years of CDC data that revealed minority patients were 22 to 30% less likely to receive any analgesic medication, and 17 to 30% less likely to receive narcotics relative to white patients who presented to emergency departments with abdominal pain. As far as long bone fracture management, Latinx patients were 50% less likely than white patients to receive opioid analgesics for isolated long bone fractures. And a study published in the Western Journal of Emergency Medicine in 2015 showed that Black patients were less likely to receive opiate analgesics than white patients for low back pain. So I think one of the key issues with these papers is someone could say, oh, well, should we really be prescribing opioids for low back pain? Aren't there other treatment methods like NSAIDs or lidocaine patches, steroid injections, physical therapy that has been shown to be more effective and less adverse risk? And while that is the case, these studies really just highlight that these physicians who were involved in the study, they weren't delivering the same treatment to their Black patients as they were to their white patients, or to their Latinx patients as they were to their white patients. So you see here that there are disparities in pain management experienced by minority populations in this country. Some other studies showed the same really findings. There was 10% less likely to receive opioid analgesics for patients who presented to the ED for abdominal and back pain. And I found it most surprising and a bit disturbing that this trend even was prevalent for pediatric patients. So pediatric patients who had recently undergone a tonsillectomy and adenoidectomy had actually 30% less likely to get opioids for pain management over white patients. And in that particular study done by Jimenez et al., the average age of the patient was 8. Then just a few more studies. So in 2018, there was a study performed that showed that Black patients were 50% less likely to be given opioid analgesic in the ED and 75% less likely to be prescribed opioids upon discharge after a motor vehicle collision. And the study looked at patients who came in within 24 hours of an MVC and ultimately were discharged home. So not anyone who had to be admitted to the hospital. And there was another study that showed that Asian patients who went to 2 outpatient primary care clinics in the academic setting located in San Francisco were 3 times less likely to be prescribed high-dose opioids for chronic non-cancer pain. So again, those studies just show the research that has gone into establishing that, yes, there are differences in pain perception and differences in pain management experienced by minority patients, specifically persons who belong to populations identifying as Latinx, Black, and Asian in this country. So I included this slide here from Serena Williams. I don't know if anyone remembers this from several years ago, but when she had her daughter, she basically ended up being diagnosed with a PE shortly thereafter. And she was interviewed by Vogue and delivered a story about how she really had to advocate for herself because initially she was becoming short of breath and she was having a lot of pain and she felt like her medical team was just writing her off. And she had to advocate for herself and demand to have a CT scan so she could be diagnosed properly. But I think it was really important and interesting at that time because it showed that even a celebrity who is a millionaire and the greatest tennis player in the world experiences health disparities. So that makes you concerned if Serena Williams can go through this, what does the average patient experience? So briefly, the social determinants of health are often talked about within the health equity space, but they're defined by how the places where people work, play, live, and learn affect their health risks and outcomes. 40% of a patient's health and well-being is determined by socioeconomic factors. Another interesting factor that plays into pain management disparities that goes beyond just differing physicians' perception of their patient's pain level based on race or difference in prescribing appropriate pain treatments is whether or not there is a pharmacy located where your patients live. So currently, 1 in 3 neighborhoods in the largest metropolitan areas in the US qualify as pharmacy deserts. And a pharmacy desert is defined as a city in which the city center does not have a pharmacy within 1 mile. And you think about how does this become a pharmacy desert? It's that way because patients who live in this area are unable to get to a pharmacy to fill their prescriptions. And also when you add on access to transportation, you see that many of the pain management regimens that you may prescribe may never actually be filled. And unfortunately, these pharmacy deserts are more common in medically underserved and minority communities. There was an article in Health Affairs in the May 2021 issue that cited Chicago as having the most pharmacy deserts within the US. Despite the United States becoming more diverse over the last several decades, 80% of large metropolitan areas in the US were more segregated in 2019 than they were in 1990. So I think up to this point, we've really spoken about how does all of this kind of play into health disparities and what we see in terms of pain management disparities. And now we are going to talk more about what you as an individual physician or physician in training or medical student can do to be more aware of your own implicit biases and address pain management in an anti-racism way, looking at it through a specific health equity lens. I would like to just stop here. Does anyone have any questions right now? Okay. So what is implicit bias? So putting the terms together, implicit is a belief, thought, or feeling that you are unaware of. And then bias is a preference or aversion to a particular characteristic or group. Implicit bias is therefore a subconscious belief that affects your view of certain groups. So you can have a preference for or an aversion to groups based on visible characteristics such as age, race, ethnicity, gender identity, disability, primary language spoken, anything based on appearance that you can see or assume. The key when we talk about implicit biases are that you have to accept that everyone has biases. Everyone has aversion to certain things or a preference for certain things, for certain looks or places, you have to accept that biases exist and that you have biases. So what is wrong with bias, especially in the healthcare setting, if we all have them? The problem is that these biases can negatively impact how a patient is evaluated and treated in healthcare settings. So we can talk about some of the concepts of cultural competency in relation to managing implicit bias, which is being aware of one's own culture and language and how it may affect others. Knowledge of certain cultural patterns to assist with care, but making sure not to stereotype, but more coming at from a place of awareness and education and wanting to learn. Implementation of skills related to cross-cultural and cross-linguistic interactions, and knowing that the term cultural competency is really a misnomer, and that one can never be competent in a culture, especially someone else's culture, and that competency really is a term to indicate a continuum and really cultural sensitivity. So I urge everyone on this talk to take one of the implicit bias tests if you haven't. They are on the Harvard website through Project Implicit, but you can take many different tests that will look at what your biases are in terms of gender identity, skin tone. I myself took a few of these tests and it can be very informative. And I urge you to take these results as not a way to feel embarrassed or ashamed, but how can you learn from your results and then move towards being more aware of your biases and making sure that you are not acting on these biases. So studies have shown that factors that contribute to bias come from pressure for time, lack of knowledge related to decision-making, cognitive overload, and fatigue. So if you look at these aspects, these are all factors that are inherent in the emergency department, right? You only have so much time to see a patient before another sicker patient comes in. You may not have any information about a patient who comes in obtunded, is unable to tell you their medical history. You have to go based on your physical exam and your medical knowledge. Cognitive overload is real. You get interrupted so many times in the emergency room that you have to be great at multitasking, and fatigue, especially for the residents who are listening today. You're working more than 80 hours a week. How do you manage just dealing with that fatigue and not letting it tire you out and create empathy and cognitive decrease and burden and burnout? So these are a few other aspects that are informative when you're taking a look at cognitive overload and thinking about the emergency department. Again, we just talked about time constraints. You're often carrying multiple patients at a time. So you have to know how to work through that and make sure that you're giving everyone that you're seeing quality care. Again, you can get a new patient who is more sick than your last patient at any time. There is the thought of the perceived, again, I put in quotations, difficult patients, but patients who you may be leading a resuscitation in one room, and then you have a patient from another room who is yelling out, asking for a blanket. And sometimes that can be perceived as difficult just because you have competing demands. Often, again, having incomplete medical information or records, if you cannot find anyone to give an ancillary history, or the patient has limited information in their chart and they're unable to provide you with a complete history. Also, you are the initial evaluator, so you have to determine what are you concerned for in this patient, what are you not concerned for. Frequent interruptions, whether it be the medical command phone, a question from a consultant, nursing questions. You have a lot of conflicting information that is coming at you at all times, long and multiple shifts, trained to triage. So often when we are taught in residency, we are taught to look at the first 5 minutes of what a case is telling us and not going back to reassess, maybe like we should. And you're also dealing with patients during their most vulnerable times. They're sick, they're in pain. So that can sometimes bring out some different aspects of people that maybe you have difficulty dealing with. In the 2017 ACEP Now, one of the ACEP Now articles was about addressing implicit bias in the emergency departments. And for that article, Mr. Quinn actually interviewed Dr. Cheryl Heron, who is a leader within the health equity field, especially for emergency medicine physicians. And she mentioned the pause technique to address implicit bias. This technique was actually developed by Cook Ross, who was the founder of an organizational consulting firm that does DEI work throughout the country, but it has since been used in healthcare settings to give physicians a framework for how they can think about addressing implicit bias during physician-patient interactions. This can be used during physician-physician interactions, physician-nurse interactions, but how can you do what the mnemonic is saying, but pause and actually think about these things. So the P is for pay attention. So you want to pay attention to what you're feeling and how you may see that your bias is being presented. You want to acknowledge that you have bias and acknowledge your assumptions. You want to think about and understand your reaction. And then you want to search for constructive alternatives and other perspectives of how can you realize that you're thinking in a biased way and how can you then reframe that? And then based on those alternative perspectives, you want to determine what is a good strategy for executing a change in behavior. Some other bias reduction techniques from the literature include individuation, which is seeing the patient as an individual and not a stereotype, perspective taking, increasing opportunities to make contact with individuals from different groups outside of the work environments, outside of the patient-physician encounters, having a basic understanding of others' cultures and where your patient population for your ED comes from, making sure to ask questions, practicing evidence-based medicine and really following guidelines in terms of pain management, and becoming an upstander instead of a bystander. So that really has to do with taking these concepts of implicit bias reduction to the next level of not only managing your own bias, but being an advocate when you see microaggressions and biases happening and how to speak up on behalf of the person who is having the microaggression against them. And lastly, I'd like to conclude with this model for anti-racism in the emergency departments. This is from the Annals of Emergency Medicine, and it was published in 2021. It was created by Nicole Franks and her research team. And here you can see there are several levels or aspects to anti-racism techniques for emergency departments that they recommend. But on an individual level that you can see up here, they task individuals to do several things. First of which is to learn the history of racism in healthcare. So I know the first few slides of this talk may have made some people listening or watching uncomfortable. And I urge you to, instead of leaning back from these uncomfortable feelings, but to instead lean in and do more research and look into more of how this country was formed and how the inequities in how this country was formed is still present today, and how that presence then affects health disparities. They then task individuals to partake in some type of implicit bias education. There are a lot of great online modules that are out there. Again, I think it's great to start with the Project Implicit tests that are offered on the Harvard website to really get a pulse on where you are with some of these topics. Third, they recommend cultural humility, and competence training. Then thinking about how do you dismantle white supremacy ideology. So again, how are some of these things that we talked about earlier, how are they still prevalent today? And how do you dismantle these institutions, these frameworks on which American medicine is built upon? And then lastly, it really tasks you to become not only a learner of this, but an educator. So tasking you to advocate for anti-racism talks within your institution and becoming an educator who can guide these conversations. I do have a slide on references, but all of my references were included in my notes on the talk. So when this gets uploaded, they should be all visible, but I'll make sure that that is included. Does anyone have any questions?
I do. That was awesome, Dr. Smith, or you like to go by Kristen. I really enjoyed it. But as a medical student or an intern or someone who is not, I guess, an attending, how do you approach if you feel like a colleague is not taking a patient's pain, seriously, as I would say, or to the extent that the patient is experiencing it?
Right, that's a great question. So again, now as an attending, I guess I have a different viewpoint because I kind of lead what the patient is going to be treated with. But I think as a medical student, as a resident, it's important that you do not let your attending's viewpoints bias you and that you continue to advocate for your patients. So it's great that you're doing that. I like to start first with, everyone has a different level of pain perception. What may be a 10 out of 10 of pain for me won't be a 10 out of 10 pain for you, won't be a 10 out of 10 pain for your attending. So I like to really start and frame the conversation that, okay, if the patient is telling me they have 10 out of 10 pain, that is what they are believing, and that is what their pain score is right now. So when I speak to patients and when you speak to your team, you say, well, this is what they're saying right now. Even if we are questioning whether this is true, this is their experience and this is their perception. And how can then we work to make sure that we're decreasing that pain level? Even if we're looking at it as like, oh, your vitals are stable, you're not tachycardic, you're not tachypneic, which may be indicators of pain that you can objectively see on a monitor or see on your physical exam. You can then at least guide it to say, well, if a patient was saying it's a 10 and we give some type of analgesic and then we reassess and they're saying now it's an 8, we know we have at least achieved some decrease or a change, a delta in that pain score. So that's really how I like to frame these conversations. I also like to make sure that when people are writing off a patient's pain, if there are any abnormal vitals, I make sure to bring that up. Okay, so you're telling me, sometimes I'll have some of our nurses say, oh, this patient is always here. And they're saying they have a 10 out of 10 pain, but they're, I'm going in, they're texting on their phone, they look fine. I don't think they're really in that much pain, what have you. But then you notice and they're tachycardic into the 120s. So, well, where is that tachycardia coming from? We need to delve into that and find out what is happening. And that to me is a physical manifestation of pain, and we need to make sure that we address it. So I think making sure that you first make sure that others' opinions don't bias you and how you're assessing and treating your patient. Second, believing the patient and at least using the pain score to look at it more holistically, and you can use it to look at changes in pain ratings. And then third, to also make sure that you are taking a closer look at your physical exam and your patient's vitals and their objective measures and seeing how does that relate to pain and how can some of these items maybe be showing me that the patient's pain level is uncontrolled.
That was so helpful. Thank you.
This is a really great session. I definitely learned a lot here. And I'm saying that as someone who if I do a fair amount of my own work to try and educate my colleagues about implicit bias and finding topics to discuss. So even with all the reading that I do, I mean, there's so much more that I learned from this talk. So I really appreciate your time and your expertise, Kristen. And yeah, I think that I was kind of thinking about how would I respond to that question about educating, team members and trying to make sure that we're taking patients seriously. I really do think that it's important to always remind people that people cope with pain, respond to pain, sort of embody pain in very different ways. Yes, we're all used to seeing the patient who is tearful or screaming or writhing, and for whatever reason we sort of make that the sort of benchmark or the standard for pain, when really there are so many people that are not so outwardly expressive, and it's a different thing from person to person that has nothing to do with any sort of aspect of your social identity. It's how we respond. I find that for me, I am biracial, but the white person in me really wanted to take a really deep dive and kind of learn about implicit bias by talking to other white people. And I found that in conversations, especially when it comes to race, just using a lot of I statements, I know for me has been really helpful and tends to help facilitate a conversation if it seems like someone might be on the verge of closing off. And I'm not advocating that we make this conversation easier or support white comfort in any way. I just find that when I say, well, here's my experience, here's what I've learned from treating patients. If this was my mom, I would want to make sure that I was taking them seriously and I believe them when they tell me their pain is 10 out of 10, even if they're on their phone. And so, that's one thing that I do try to incorporate at my workplace is just say, if it were me, I'd be pretty upset right now if I were being denied pain management, because guess what? When I'm having terrible back pain or whatever, I'm on my phone. I'm not screaming out. I'm going to be on my phone, and I would expect my pain to be treated the same way. But I really do think probably one of the more important things there is to really make sure that everyone understands that every human being is different, and we cannot gauge someone's sort of pain that they feel based on what we see in front of us, because that's when our biases are activated. So I just wanted to throw that in there. Does anyone, so we're a little over 6 p.m. I really appreciate this presentation. It was really excellent. Does anyone have any other questions, comments that they want to bring up before we adjourn for the evening? All right. Well, thank you so much again, Dr. Smith. This was incredible. Thank you so much. For everybody in attendance and also for those watching later on, we will have the recording for this session available on the AAEM JEDI website within 48 hours. And you can also go to the website to register for future mentor sessions, get other information about what's going on in our section. We will likely be hosting our next webinar in July, so stay tuned for more information on that. If you're not already a member of our section, please sign up, and that way you get the emails that go out to the entire section so you can stay up to date on everything. Thank you again so much, everybody, for coming tonight, and that concludes our program. All right, take care.
Thank you, everyone.